Dr. Weiss, why would a patient consider coming to the urgent care facility like the doctor's in as opposed to going to the emergency room?
That's a very good question. Um, I would say that what I like to tell patients is that there are multiple answers to this question. On the surface, what I can tell you is that an urgent care center can handle most of the patients who would be coming to an emergency room, not all of them, but most of them, more cost effectively, more quickly, and more efficiently than an emergency room can. But regarding the doctor is in, what I would specifically say is that if you go into an emergency room and stand there and count all of the patients who come into an emergency room in a 24-hour period, what you will find is that perhaps 80 to 90% of those patients end up walking into the emergency room. They spend some time there, they're treated, and then they go home. They have no critical cases or issues in this particular segment of patients. The more critical segment, of course, they're going to be admitted to the hospital, they're going to need operations, they're going to need surgeries and critical care and further attention in the hospital. And this, as an old ER doctor, this was my experience, that about 80 to 90% of the patients I would see as an attending in the ER, I would eventually discharge and they would leave to go home, and about 10 to 20% would be so sick that I would have to admit them for further care in the hospital. So in general, what I would say is, if you think, usually patients in general have a feeling as to how sick they are, and if you fall ill or have a medical issue and you have a feeling in you that you're going to be going home after seeing the doctor, you should come to the urgent care center. If you feel so dreadfully ill that you have a feeling that you have something life-threatening, you should be going to an emergency room. Regarding the doctor is in, I feel that we can serve those patients with non-critical medical issues in a superior fashion here at the doctor is in to the ER. And the main reason for this is because I have often found with emergency room care that the doctors in the emergency room listen to the complaints of the patients, and then based upon those complaints they attempt to rule out the critical and life-threatening problems that might be associated with those complaints. And then once those rule-outs have been done, the patient's discharged. But their complaint was never addressed. So for example, if a patient comes into the emergency room with chest pain, a common approach in the emergency room will be to make sure that the patient doesn't have a life-threatening cause of the chest pain. For example, they're not having a heart attack, they're not having a dissection of the aorta where the aorta is not splitting open, they don't have a pneumonia in their lungs. But once those determinations are made, the patient basically is discharged without really help for or consideration as to why he has his or her chest pain. And that makes up the majority of patients coming to the emergency room with a problem like chest pain. Actually, it's only a minority of patients coming to an emergency room with chest pain who actually have a heart problem, a pneumonia, and the vast majority have more minor problems like anxiety or heartburn or a pulled rib muscle. And I believe that in an emergency room setting, these concerns are ignored. And at the end of the emergency room visit, after making a determination that the patient does not need critical care from an ER or a hospital setting, the patient will be told to follow up with their doctor, their primary doctor, which perhaps should have been done in the first place. Or, I think that as the doctor is in, we actually will see these patients, determine what their cause is, and then primarily help them with any cause that they may have of their complaint, and then actually follow up with them and make sure that it's gone and everything is addressed not only in an urgent care setting, but continue with them in a primary care follow-up.
That was my next question. How important is the follow-up to a minor critical, non-critical issue where the patient would never be admitted to the ER, but like you said, their symptoms were ruled out, but the cause was never treated or found out?
It is extremely important, especially in a continuing way, to make sure that the patient is not plagued by recurrences of their symptoms. You have to remember, if someone goes to the emergency room because they have a bad knee pain or a bad chest pain or a migraine, even if the ER care were to solve their problem and cure their symptoms on that day, it doesn't mean that the emergency room is going to do things to prevent this process from returning in a week from now, 3 days from now, or a month from now. And that's exactly the role of primary care, to figure out the cause, to take away the cause, and to make sure the patient has smooth sailing and doesn't have recurrent symptoms on other days.
What types of follow-ups would you do on a patient who came in with symptoms, with nagging symptoms, are they invasive, are they testing, are they just follow-ups on vitals?
That's a very good question, because I think your question exposes the difference between what we do at the doctor's in an emergency room. In general, in an emergency room, when an average person goes in with any given complaint, a lot of tests are done. And of course, this enormously raises the cost of health care. In our setting that the doctor is in, rarely are tests done, because instead of tests, what we do is we actually, our intake of information and gathering of data tends to be geared towards listening, spending time with the patient and listening, gathering history, personal information from them. That information yields the cause of their problems, and generally tests don't. If you look at tests that are gotten in by any given doctor anywhere, or an emergency room or hospital, they're usually negative. And a lot of CAT scans, a lot of blood tests, 95% of the results are all normal or negative. That doesn't help discern what is wrong with the patient and what we should do next. And I think if the doctor is in, we spend the time actually talking to the patient and use that as a method to find out what's wrong with them. And we find the answers.